Good afternoon, and welcome to the latest Facebook Live event hosted by the National Cancer Institute. My name is Jamie Troyle-Goldfarb, and I'll be today's moderator. I'm here because I am a stage 4 melanoma survivor, and I owe my life to a clinical trial conducted at the NCI. I'll talk more about that in a minute, but first, more importantly, I'm pleased to be joined by two experts in melanoma, key opinion leaders, Dr. Stephanie Goff of the National Cancer Institute and Dr. Jason Luke from the University of Chicago. Would you like to introduce yourselves?
Hi everybody, I'm Stephanie Goff. I'm a surgical oncologist here at the National Cancer Institute in Bethesda, Maryland.
Hi, I'm Jason Luke. I'm an assistant professor of medicine at the University of Chicago, where I specialize in the management of melanoma.
Wonderful. We all welcome you to what promises to be an interesting discussion about melanoma and current state and future of treatment and research. In conjunction with the topics that we discussed today, we encourage you to ask questions in the comment section of the Facebook feed, and we will answer them at the end. And throughout the broadcast, we will be providing links to NCI resources in the comments section, as well as other information like how to contact NCI's Cancer Information Services at 1-800-4-CANCER. So that our experts are able to get to as many questions as possible, please limit your questions to today's topic, which is melanoma. Okay, let's get started. So I'd like to start by telling everyone a little bit about my cancer journey. I had a birthmark on my left thigh that changed over time, and by the time I finally got around to getting it checked out, it turned out to be melanoma. It was removed, and I had a surgery that is called a wide excision, where they take a block of tissues from around the tumor to make sure that the cells had not spread. That was all clear. I thought, okay, done with that. Never considered myself as having had cancer, never really thought about it at all, except that over the course of the next year, I had recurrent infections in my surgical site, and my surgeon's office kept saying, oh, that has nothing to do with us or with cancer, that's just a coincidence, just get those treated with your primary care physician. And then finally, after the third infection, they agreed to go back into the site to see if they had left something behind, like a suture that was causing the infections. And what they found was a massive melanoma in the deep tissue. So at that point, I was stage 3. Now, this was 2010. And so there wasn't a lot of information available for stage 3 treatment at the time. And so we consulted with several melanoma experts. Everyone agreed that that was kind of a freak occurrence in the deep tissue and said, go ahead with your life and we'll just watch it. I had a PET scan that was clear. The margins from the second surgery were clear, so we went on. The next month, I became pregnant with my son, Kai, and so we didn't do anything. Before I was supposed to return to work from maternity leave, my oncologist suggested that we do a PET scan just so that I could start back to work with confidence, and because we hadn't done anything during while I was pregnant. And that PET scan showed that while I was pregnant, the cancer had metastasized to my liver and my pancreas. So at that time, with a day before I was supposed to return to work from maternity leave with an 11-week-old baby, I was stage 4. So that was January 2011. At that time, there were only 2 approved treatments for melanoma. One was chemotherapy, which we know is not effective for late-stage disease, and the other was high-dose interleukin-2. But it was a promising time for research, and there were a lot of good options in clinical trials, many of which are approved treatments today, which is wonderful. And melanoma has only about a 14% 5-year survival rate for stage 4. But I had an 11-week-old baby. Those stats were not going to work. So the next couple weeks were a flurry of information gathering, seeking out melanoma experts, gathering opinions, learning about all the research, and ultimately, unanimously, everyone decided that I should enroll in a clinical trial at the National Cancer Institute for TIL, for adoptive cell treatment, which Dr. Goff will do a great job of explaining in a little bit later in the broadcast. But in the meantime, so the process for TIL is that they take part of your tumor, take all the white blood cells that they find in the tumor, because those cells had stumbled upon and knew how to attack melanoma. They replicate those in the lab by the billions, and then in the trial that I did, they also genetically engineered the cells to express interleukin-12 upon contact with tumor. So that whole process of growing the cells is a complicated process, takes 4 to 6 weeks to be successful. And in the meantime, we decided that instead of just waiting, we would do high-dose interleukin-2. So I did high-dose interleukin-2. I did 4 rounds of it. It's a week in the hospital, week out, week in the hospital, week out, so on. And my last dose of IL-2 was in April of 2011, and then I had follow-up scans every 4 weeks. Scans in April, May, June, July showed that it was working. The tumors were shrinking. And then my August scans showed about 35 new subcutaneous tumors had grown in that 4-week period. So then we decided to proceed with TIL. So I did the TIL treatment at NCI in the clinical center on the NIH campus. The month of September, it's a month inpatient treatment. First I had 5 days of high-dose chemotherapy to kill my system, not to treat the cancer, but to deplete my immune system so that I could get the new cells when I was completely neutropenic when my cells were 0. So when that happened, I got the new cells, and then we waited for the cell counts to come back up until I could go home. And then after that, I was followed every 4 weeks for scans, and scans in September, October, November, December showed that the treatment was not working. The tumors were growing, and we decided that we'd talk about next options during my January scan. In January, the scan showed that the tumors were shrinking, and then they shrank progressively over the next 2 years until I was finally completely disease-free with no evidence of disease at all. And I remained that way 3 more years, and I expect to remain that way forever, knock on wood. And now my little 11-week-old baby is a 6.5-year-old who I have the pleasure of spending every day with. That is because of a clinical trial at the National Cancer Institute. So that's my story. And enough about me. We will get on to the experts, and we will start asking some questions about melanoma. Dr. Goff, can you give us a basic description of what is melanoma, how many people are affected each year, and how can you prevent and detect it?
Absolutely. So melanoma is one of the rare forms of skin cancer. Skin cancer is fairly common here in the United States. You probably know a friend or family member that has had a skin cancer removed. Those are usually cancers that are called basal cell or squamous cell cancers. But about 90,000 people a year will be diagnosed with this very rare form of skin cancer called melanoma. And that comes from a very particular cell that exists in the skin that's responsible for pigment, called a melanocyte. When those cells go awry, they can develop into something that looks like a mole. And so you need to be on the lookout for moles that change. We all have about a 2% lifetime risk of being diagnosed with melanoma. But very much like Jamie said early in her story, the best and quickest way to treat it is with surgical therapy. So a wide local excision with the right margins by a surgeon who understands melanoma very often is the last anyone ever has to think about their melanoma. More than 90% of patients who get an early stage cancer never have to worry about their melanoma again. But you also heard from Jamie that it can come back. And so there are some treatments that we use for advanced disease called adjuvant. So after you've resected everything that you're worried about, there are some treatments that can try to prevent it from coming back, and there are 2 that are approved by the FDA. How can you prevent it? This is Melanoma Prevention Awareness Month. It's the things you've heard your entire life. Avoid the sun. If your lifestyle or hobby or job makes it such that you can avoid the sun, protect yourself. Broad-brimmed hats, UV-resistant clothing, good sunscreen. These things can help affect the UV changes that might happen to your skin. But by far the most important thing is to know your skin. Have a doctor who knows your skin, whether that's your family practitioner or your dermatologist, so that you can keep track of things that are changing. You should get familiar, if you are a person that has many moles, get familiar with the ABCDs of melanoma, and we can provide a link for that here.
Can you talk a little bit about what advances in research have been made in the last 5 to 10 years, Dr. Goff?
Sure, absolutely. So like you mentioned when you were retelling your story for us, at that time there were only a couple of things approved for melanoma. One is a chemotherapy called dacarbazine, which actually has a fairly high response rate, meaning measuring tumors getting smaller. What we do know from that, however, it doesn't last. It's very short-lived. And so there clearly needed to be newer options for that. Interleukin-2, like you discussed and you received, is a way of sort of stimulating all the T cells in the body. And when we were, Dr. Rosenberg was developing that here at the NCI, he was trying it in a bunch of different cancers. And what he found was that it started to work in a patient with melanoma. And it turns out melanoma has actually been this wonderful model for understanding how the immune system can react with cancer. And many of the trials of the drugs that are now being approved all started because they work in melanoma first. What we found, interleukin-2 can put the gas onto all those, if you think of those T cells as a car just ready and waiting in your body. The problem is a lot of those T cells also have a brake on. And that brake is a system that's been discovered called checkpoints. And it's a way our body has so that our immune system can attack something that it needs to, but it can get shut down before it goes awry. And we learned how to block that. And I think Dr. Luke can probably talk with a little bit more expertise on checkpoint blockade because he's able to treat patients at the University of Chicago with those medications.
Absolutely. And I think when we talk about all of the progress that has been made in the treatment of melanoma since 2011, there have been 11 FDA approvals of either new drugs or combinations of new drugs. And it's really changed the landscape quite dramatically, such that melanoma, maybe more than any other cancer, is literally leading the way in terms of new drug development and research for all of cancer. But in that context, I think in addition to immunotherapy, there are other treatments, and we should probably just outline all of them so people have heard about them. And when I talk to patients, I really sort of usually split things into two buckets. It's probably worth pointing out that though chemotherapy is still occasionally used for melanoma later on in treatment, it's not usually considered as the first treatment that patients would be considered for. Now, that being said, the two sort of broad buckets that we think about are genomically targeted therapies, or precision medicine, as you may have heard of. In that context, probably most in the audience will have heard that half of people with melanoma have a mutation in the melanoma that makes the melanoma grow called BRAF, B-R-A-F. And that's important because drugs in a precision medicine fashion have been developed to go after that BRAF mutation. And they have various different names, and they're from different companies, and that's not so much the importance, but rather that they can be very effective. They sort of work like antibiotic pills in that you take them, they usually shrink the cancer fast. And historically, they've been associated with dramatic benefit, although not always lasting as long as we would wish. So that's definitely an area that people should be aware of, and BRAF is the mutation that people are most familiar with, but it's worth pointing out that a lot of research is ongoing to look at other mutations in melanoma and try to develop drugs against them. And some of those mutations have names like NRAS, NF1, KIT, GNAQ, and GNA11. I'm not going to sort of belabor it so much, but rather just to have said it so that people in the audience can have heard that, to know there's a lot of research going on in that space. In this program, though, we're really focused on immunotherapy for melanoma. And in that regard, the checkpoint inhibitors have been highlighted just a little bit ago by Dr. Goff. So building on the seminal research at the National Cancer Institute with Dr. Rosenberg with the identification of interleukin-2, and about 10 to 15% of people who could get that treatment and have long-term survival, perhaps even cure with that treatment, it was an understanding that really we could harness the immune system to fight cancer. And seminal discoveries in the late 1990s by Jim Allison, who's a doctor that's probably going to win the Nobel Prize for this sort of discovery, has really set the stage for us understanding how to harness these checkpoints and block them for cancer immunotherapy. And in melanoma, the first drug in this class was approved in 2011. It has the name ipilimumab. It's an anti-CTLA-4 antibody. And as was mentioned, CTLA-4 is sort of like the master off switch in your T cells, which are your immune fighting cells. So by blocking the off switch, the idea is we could keep the immune system more on and therefore maybe fight cancer more. And we now know with ipilimumab that about a quarter, maybe 20% of patients with advanced melanoma, meaning it's spread all over their body, can get long-term benefit, and similar to IL-2, staying alive long-term after getting ipilimumab. And that's very exciting because, again, we're raising the bar from 10 to 20. The next big step was the identification of molecules that are actually in the tumor microenvironment that inhibit the immune cell activity. So we're going to talk about this more, but a model for understanding how this immunotherapy works with the checkpoint blockade is that some patients have immune cells that have actually gone into their tumor. And once they get there, they actually sort of start to attack the tumor, but the tumor will notice them and will upregulate other immune suppressive molecules, one of them a molecule called PDL1, or programmed death ligand 1. And if the PDL1 interacts with the PD1 receptor, it turns off those attacking immune cells. And if they sleep too long, those immune cells, they undergo something called programmed death. So now you start to understand all these acronyms. And once that was identified, it was really obvious then that we might be able to develop a checkpoint inhibiting drug against PD1, and that has been wildly successful in melanoma with the development of the drugs pembrolizumab, and I sometimes tell patients that's the Jimmy Carter drug, or nivolumab, which is on TV a lot as the drug you've heard called Opdivo. Further developments in that space have been combining these drugs together. There has also been further investigation into the use of viruses that have been engineered in the laboratory to infect the melanoma and to kill it. And so all of these things, as one drug alone or in combinations, are now becoming part of the standard of care treatment of patients with melanoma, and really are moving into the future research of clinical trials about how to use them optimally and which combinations are really going to be the most efficacious into the future. And we're going to discuss all of that further, but I think at this point, after raising the idea of these immune cells that can go into the cancer, I'm going to pass it back to Dr. Goff, because her expertise in the National Cancer Institute are doing some very interesting things, trying to use those cells directly, taking them out of patients. But I'll pass it back to her to discuss that.
Absolutely. Thanks, Jason. So when you think about immunotherapy, you want to think about the way our bodies can handle the fact that there's a cancer there. Why do they recognize it? They've realized, for some reason, that it doesn't belong there anymore. Now, the immune system is designed to fight things that are so-called non-self. So you get a virus, you get a flu, your body turns on, gets rid of it, and you get better. Fortunately, we don't have any drugs to make that happen faster, and so a cold still lasts about as long now as it did 100 years ago. But we have learned that we can turn the immune system on and off. And how can we figure out better ways to help that? So we like to think of it in sort of three general areas. How can we kind of non-specifically turn on all the immune cells in your body so that if there are any there that know how to attack your cancer, they can get turned on? And those are the things we talk about with either a stimulating drug like IL-2 or a checkpoint blockade, taking those brakes off like ipilimumab, pembrolizumab, and nivolumab. In addition, there are some drugs being looked at now that change what the tumor looks like and prevents it from stopping the immune cells from working. So that's using all of the T cells in your body on the off chance that the right ones are there. A second way is to try to train the cells that are in your body. And a lot of the viruses that Dr. Luke mentioned are trying to do that. This is the world of vaccines and trying to raise an immune response against a cancer. The third way is to study those cells outside the body, make them as active and as potent as we possibly can, and then give them back. And that's the kind of therapy that Jamie described, which I'll admit to you, when I was a medical student, sounded like science fiction to me. So what we do is we take a tumor. It requires an operation. We then take that tumor into the lab, chop it into tiny pieces. We feed it with a lot of that stimulating medicine, IL-2, and what we find is that the tumor goes away and lymphocytes grow. So lymphocytes that lived in that tumor, that were actively there and maybe trying to fight that cancer, but not quite tilting the teeter-totter enough to make it go away, could be grown in large numbers. We can sometimes study those cells against the tumor that we took them from and show that they make all the things that should let them kill. They make things like interferon gamma and IL-2 and things that make them killing machines. They live up to their name as killer T cells. When we get ready to give those cells back to a patient, much like we did with Jamie, the reason we use a chemotherapy, this is not chemotherapy like most people get. We don't expect the chemotherapy to have any effect on the cancer at all. What we want is what people normally think of as a side effect. We want it to knock down the immune system. We want to make sure all those lymphocytes are gone. We want to make sure all those neutrophils are gone to create this wonderful, empty, rich environment that we can dump billions of cells into. So we give a little chemotherapy to get our patients ready for that. We did that to get Jamie ready for that. We then give those cells, and sometimes we're able to give as many as 120, 130 billion cells. If you think about that, that's sometimes as many as 20 for every man, woman, and child on Earth. They have all that room to grow, but they need to learn how to live in a person again rather than in a dish. And so we give IL-2 to our patients to help them learn, to help those cells grow. That process, Jamie told you, has you here in the hospital with us for about 3 to 4 weeks. And it's intense. It has to be. We're giving you a new immune system that we hope can overtake the cancer. And when we did it in patients like Jamie, what we were finding is that we could make all the cancer go away in about a quarter of patients. And we have enough follow-up now. We're looking 6, 7, 8 years later. Those 25% of patients still don't have any melanoma. So we had developed a treatment that was capable of getting rid of the last cell. Now, obviously, it's not feasible for every cancer center in the country to give this sort of intense treatment. That's what we specialize here at the National Cancer Institute. We do these things that are a little more difficult so that we can learn things about the immune system that can become more generalized. One of the things we learned is that what those cells were recognizing was that every patient's cancer changes just a little bit. It has some mutations. And those mutations aren't the ones that you are used to hearing about, like BRCA in breast, or KRAS in colon cancer, or BRAF in melanoma. There are these random mutations and breaks that happen in the DNA that make something look just slightly different. It doesn't change how the cell functions necessarily, but it does make it look a little different. I'd like to tell my patients, if you think about walking into a parking lot and all the cars look the same, all of a sudden there's one that has an antenna topper, so you know that that's different. That's what these mutations are doing to the cancer cells, and that's how the immune system knows how to find them. So we're still constantly learning. We've been doing TIL since even long before Jamie had her treatment, and we're still refining and learning. And the principles that we've learned in melanoma, we're now able to extend to patients with colon cancer, to patients with breast cancer, to patients with other kinds of epithelial cancer. So it really still is a model for what we're learning. So immunotherapy has a wide range of applications, from something as relatively simple as getting an infusion of an antibody that takes half an hour, to these very complex sorts of treatments that can take 3 to 4 weeks. The goal is all the same. Our immune system is a powerful thing, and if we engage it in just the right way, it can get rid of the last cancer cell, and that's what we're trying to do.
That's wonderful. As we've been talking about, a lot of these, all medicines start in clinical trials, and a lot of the things that we're discussing are still in clinical trials. I owe my own life to a clinical trial. And so could you talk a little bit to our audience about what a clinical trial is, how melanoma patients can find them, and how to access them?
I think Dr. Luke might be able to talk more specifically about the wide range of clinical trials that are available across the country. I can speak more specifically to the more detailed ones that we're able to do here at the NCI.
Sure, and I think this is a really important discussion that I have with all my patients, and especially the first time I see them actually, is trying to get them to a place to have a better understanding of what is clinical research and what are clinical trials. So commonly I find that people and families and patients, they've heard of clinical trials, but they hear of it as a, quote, experiment, and it sort of sounds scary. And in reality, it really doesn't need to be that. It just needs to be that people need to have an understanding of what's going on and make a decision that they would want to pursue that. So many people have heard of a clinical trial, and they commonly have heard of a situation where you either get this drug over here or this drug over here. Sometimes you get randomized and you don't get to choose, and then sometimes you get a placebo. Those kinds of clinical trials are called phase 3 clinical trials, and honestly placebo use in oncology really isn't that common anymore because we have many drugs to try, but that's a clinical trial where we're trying to really prove on a very high statistical level that one treatment is better than another. A phase 2 clinical trial has to be done before a phase 3 trial, and that's where we take a drug that we think might work and we treat a certain number of people with it, and if we see a signal that suggests there's really something there, that would justify doing that large phase 3 trial. Before you do a phase 2 trial, you have to do a phase 1 trial. And the phase 1 trial really helps us to understand how do we give the drug, having shown that it worked in the laboratory, to human beings. And so historically, phase 1 trials really focused predominantly on safety first and sometimes only, where patients would get the treatments at increasing doses of a drug until we saw that we got to the appropriate dose. And thereafter, we would confirm that appropriate dose before we go on to do phase 2 and phase 3 trials. So that sounds to some people like being, in quotes, a guinea pig. And when I hear patients say that, I say, well, that's correct, but not quite the whole story. Because historically, we had this perspective about safety because, unfortunately, chemotherapy not always so safe. In the sort of modern drug development era where we're using these genomically directed therapies or these checkpoint blocking antibodies, predominantly what we see is that people are just fine and they don't really get sick hardly at all. It's not the case that no one ever gets sick, which is why we have to watch people very closely. But instead, in these phase 1 trials, usually what happens is that we very quickly determine the dose that we're going to move forward, and then we rapidly move into what we call expansion cohorts, where we treat large numbers of patients to try to really get a sense, is the drug working? And it's important to point out that because of this change in perspective, it's fewer and it's less common that we actually do phase 2 clinical trials anymore. Because commonly we do phase 1 to find the dose, and then we treat people, and if it really looks good, sometimes the drug goes straight to the FDA or straight to a phase 3 trial. So one example of that is pembrolizumab, which was the drug that Jimmy Carter got for melanoma, got approved by the FDA after the phase 1 trial. And I think it was something like 700 patients were treated on that phase 1 trial. So again, to inform a person, an individual patient's perspective on which clinical trial to consider, phase 1 trials might sound conceptually scary, and yet back at that time, which would have been in the 2010-ish kind of range, if people had been reticent and not willing to participate in phase 1 trials, we never would have gotten that drug, and those patients that participated back then got access to it years before other people got access. So in my clinic, in fact, most of the clinical trials that we do are actually phase 1 clinical trials. And the reason I support that is, one, we learn a lot for research, but two, it gives patients access to novel drugs much faster than they would have gotten them otherwise. And it's also the case that we're no longer looking for very slight benefits. So we used to do these large randomized phase 3 trials to show that there was a, with all due respect, a small benefit between one chemotherapy versus another. Now we're looking for home runs. We're looking for immunotherapy drugs that are allowing patients, large numbers of patients, to really do really well. So while clinical research certainly is a clinical experiment, it's important to understand that for an individual patient, it's very possible it could be the best option available to you. And Dr. Goff, in a second, will talk about the details of the clinical trials they're doing at the National Cancer Institute, but I can't stress enough that when I do clinical trials, and most of my patients, honestly, are on clinical trials, we do the clinical trials with the patient, meaning that that patient chooses this as the best therapy they think is available to them, and we do not do clinical trials to the patient. In other words, we're not doing them just to learn. Obviously, we want to learn and we want to do research, but the reason that I do clinical trials is because I think it's the best option that's available for the patient that's participating. So that's sort of an overview of clinical trials. And we have many different versions of immunotherapies as one drug, in combination, so on and so forth, that we're evaluating, particularly in people with melanoma, but really all cancers in that regard. I'm going to pass it back to Dr. Goff, however, because the idiosyncrasies and the complexity of the clinical trials that they're pursuing at the National Cancer Institute around these tumor-infiltrating lymphocytes or adoptive cellular therapies are even a step even more complicated. So I'll pass it back to her now.
Dr. Luke. One thing I try to tell people, because obviously someone finds out you work at the National Cancer Institute, you get asked questions about cancer all the time. And someone's asking me, why should I do a clinical trial? Just to hit on points that Dr. Luke made, there are two things you need to know. In the history of everything that now works, there was once a time when we didn't know if it would work, and we needed people to test that. We needed partners that were patients to help us figure that out. The second thing, none of this is a crazy idea somebody dreamt up in the middle of the night. When we get ready to give a drug to a human for the first time, it's been through years of preclinical testing, animal testing. We have a pretty good idea of what we think it's going to do. It's not as experimental as the name might suggest. When you get into the sort of studies that we're doing here at the NCI, what's important to understand is that they're not always for everyone. And we understand that. Because of the complexities of the treatment, the chemotherapy, the wait time that it requires to generate these sorts of advanced products, we have to be a little more careful about who we ask to help us. And the reason for that is we can only learn as much as we can when our patients are as strong as they can be. Somewhere else, as early in their cancer journey as possible, because the stronger our patients, the stronger our science, and the faster progress can happen. When you look at a clinical trial, it often looks like a long list of a checklist. Do I meet all the inclusion criteria? Can I be a part of this trial? Do I have any of the exclusion criteria? Is there anything that would prevent me from being on this trial? And that can give you a rough idea of whether you're a good candidate for something. But there are some complexities in there that even if you meet every single one of these and you don't have any of these, sometimes it's still just not a right fit. And so when you're speaking with people about clinical trials, it's a partnership, it's a trust, and every oncologist is out there is trying to give you, the patient, your family member, the best care possible. And sometimes a clinical trial is too complex and may actually shorten the time that a patient with metastatic cancer has. And our goal is not to do that. Our goal is to let you live a life as normal as possible for as long as possible. Our work here is and has been on the use of cells for immunotherapy, where we study the cells on the outside before we give them back. And like Jamie said, we sometimes do slight variations on that. So the first treatments were just taking the cells that could grow out of the tumor. We started to look at different things like Jamie's, where we would genetically modify those cells to make a cytokine that we thought might help. In her case, it was interleukin-12. We have also worked with taking blood cells out of the bloodstream, not requiring an operation, and genetically engineering them to look for a particular target on a tumor. This is known as T-cell receptor therapy, and it requires a unique combination of a patient's tumor and a patient's what we call a white blood cell type, or an HLA typing. We have several of those studies still ongoing. You may have seen in the news, not particularly in the world of melanoma, but there are cells called CAR cells, or CAR T cells, that have shown some remarkable responses in patients with lymphoma and leukemia. Those are genetically engineered cells too, where the cells that are taken from the bloodstream get manipulated in a lab so that they can find a target, and then they go in and they kill it. In lymphoma, that's had remarkable results, and a phase 3 trial is about to be reported and may actually lead to the first cellular therapy to be approved by the FDA, perhaps later this year. Our clinical trials can be rough. Not everyone is a perfect fit. But the good thing is there are National Cancer Institute designated comprehensive cancer centers all over the country, and they are testing medications that might be the right fit for you. And so you should really, if you have the opportunity, if you're in the right geographic location, try to get at least a second opinion consult at a place that is a comprehensive cancer center that's been designated by the NCI. You can sort of trust that stamp of approval that you've got a coordinated group of medical oncologists, surgical oncologists, and radiation oncologists looking at your case.
Yeah, Thank you. And to just second what Dr. Scoff and Luke said, clinical trials, especially for people with cancer, should not be a last-ditch effort. They should not be the thing you come to last in your treatment. They represent viable treatment options, and they're oftentimes the best way to get access to the most cutting-edge research available for patients. And it is incumbent upon all of us to be our own best health advocates and to research all of our options, including clinical trials, so that we can make treatment decisions that make sense, that we understand, and that are going to lead to the best outcomes. And doing that first is of primary importance. And being a clinical research participant, you're not a guinea pig, you're not a number, you are an active participant in your own care. You are asking questions, you are making joint decisions with your care team. And if I may very quickly tell a quick story about my experience at NCI, when I first was checking into the clinical center to start my first inpatient treatment, I was hanging up pictures of my baby at the time on the walls that faced my bed so that I could see throughout all of it, throughout all of the side effects, through all the time away, I could focus on him and see what I was doing this for. And as I was doing that, the nurses were coming in and they were introducing themselves, and they knew us, they knew our family, they knew the baby, they knew our names. And at first we just thought, wow, that is fantastic customer service. But we asked the fourth or fifth nurse, is this normal? Do you know so much about your patients before you treat them always? And her response was, yes, but in your case, the doctors walked your picture around with your baby that I had given them at my first screening appointment and shown it to all of the nurses and caretakers on the unit and said, this woman is starting treatment with us tomorrow and we are going to save her life. So I started my treatment with the utmost confidence in my care team, knowing that they were invested in me as an individual with an end goal of survival to be there for my child. I was not a number. I was a person whose life needed to be saved, and thankfully that's what happened. But it was because we were all working together, and that's the responsibility of the patient, to understand what the options are and where to go for care.
Absolutely. I can't stress more that every single person that comes onto our trial is first and foremost the patient that we are taking care of. And what's most important to us is the response that's happening in that room. Yes, people become numbers. That is later on. That is not part of the day-to-day treatment of getting someone through a protocol. Our first and last and every in-between impetus is to get the best treatment for the patient in front of us. And it doesn't have to do with research. It has to do with how well that patient is doing. It has to do with that patient's safety, and it has to do with getting that patient through the treatment. Because knowing that it can cure 25% of people doesn't matter. It's either going to work or it's not going to work for that one person. And so statistics aren't important. The patient in front of you, the person in front of you, the family care system in front of you is what's important. And I think we all, at least I know my group does, and I've actually worked with Jason when I was a fellow. I know he feels the same way.
Well, Finn.
Absolutely. And I think in the clinical trials that we run, I always, my goal is, again, to do things with the patient. And I always try to emphasize that we should always have a plan. Whenever you leave your doctor's office, there should be a plan. It may not be that you have an appointment, but you should know what the next step is. And I think that's probably a truism across medicine, that you want to find a team of doctors to work with that you feel comfortable with and that you can communicate with easily.
Absolutely. Trust in your patient care team is absolutely important. We couldn't get our patients through this rough treatment unless they were allied with our nurses and our care team. We have the benefit of an amazing building and an amazing sort of ecosystem at the NIH where everyone is involved and everyone is rooting for these patients on every level, from the person who comes in to change the linens to the doctors that are running the trials.
Thank you. So we did talk a little bit about checkpoint blockades. Dr. Luke, can you address a little bit about, have we found a way to determine if these kinds of treatments work better in some patients than others?
So absolutely. And trying to figure out which patients are going to benefit the most from immunotherapy or not benefit from immunotherapy is really actually the core research hypothesis that our group at the University of Chicago has been pursuing over the last almost 2 decades now. So I actually, with Dr. Goff, we both were early in our careers in Boston, and I actually got recruited here to work with our colleague Tom Gajewski, who proposed a model for thinking about which patients are most likely to benefit from immunotherapy that sort of simplistically you can call the inflamed versus not inflamed tumor model. And really, it sort of just makes sense that in some patients, the immune cells have found the cancer, and they start to do things that generate inflammation. And we call those inflamed tumors. Now, it's important to point out that that's not the same kind of inflammation that you would kind of normally have thought about in terms of if you have a bad diet or if you stub your toe or that kind of thing. This is T-cell inflammation, meaning your immune system has learned how to fight the cancer, is generating anti-cancer inflammation. And the inflammation is made up of multiple different parts of the immune system that are attacking the tumor, but it's really the predicate for whether or not these immune therapies are going to come in. And I'll just take a step back to think about this. It's important to point out that the immune therapies in the context of checkpoint inhibitors are really the opposite from chemotherapy. The drugs themselves don't kill cancer cells, and generally speaking, the drugs themselves don't cause side effects. Rather, if these drugs impact on your own immune cells, then your immune cells will kill the cancer, or sometimes your immune cells can cause side effects. But getting back to picking out who's likely to benefit from the treatment, again, we're working on ways to measure whether or not the immune cells have gotten to the tumor. One version of that you may have heard of was doing a test for a molecule called PD-L1. And I mentioned it earlier. It's a test that can be done on the tumor. We think that that test is of limited value. It's not that it's not any value, but it's of limited value because it only measures one thing, the PD-L1, when in reality the immune response is very complicated, made up by literally thousands of molecules, but really all centered on whether or not those immune cells, those tumor-infiltrating lymphocytes that we keep talking about, whether or not they are present. So we are doing a lot of research trying to look at what we refer to as gene expression profiling, where we actually look at what are all the genes that are turned on in the tumor, and if we see evidence that way that there is a suggestion that the immune cells are there and turning on their genes, those patients we found are very much more likely to respond and to do very well with cancer immunotherapy, really across all immunotherapies, but particularly these checkpoint inhibitor antibodies that we're sort of talking about here. One other hypothesis that's been really, really interesting, and just by coincidence got approved by the FDA yesterday, or 2 days ago maybe, was that it turns out that the number of mutations that are in the cancer, as Dr. Goff mentioned before, that the immune cells can recognize, will also help to stratify whether or not patients do well with immunotherapy. So paradoxically, often the cancers that are the most aggressive have a lot of mutations. It turns out those are probably the same ones that the immune system is more likely to mount a response against, because we've seen that the checkpoint inhibitors, the PD-1 antibodies, also appear to work very well in those cancers. So we sort of have two leading hypotheses right now about which tumors in patients are likely to be those that the immune system will attack the most. They're those that are inflamed, particularly T-cell inflamed, and those that have a lot of mutations. In understanding that, we're starting to get better about picking out who is likely to benefit the most from these treatments. Because the vice versa would be those patients with non-T-cell inflamed tumors or low mutations are not so likely to benefit from immunotherapy. So we have a lot of research to do in this space, and again sort of emphasizes why we need people to continue to participate in clinical trials and in clinical research so we can start to sort out these questions and really optimize these treatments for individual patients. One thing I will note in the context of this conversation around melanoma is that it turns out that most patients with cutaneous melanoma have both a T-cell inflamed phenotype and a lot of mutations in the cancer, and that again stems from the fact that the cancer is caused for the most part by the sun radiation and the mutations from the sun. And that's part of the reason that we've learned so much, and most of these drugs have come through melanoma first, is that they tend to work the best in melanoma. But we're taking these principles and really applying them across all of cancer now. And one obvious question is, well, if you don't have this T-cell inflamed phenotype, is there a way we could generate inflammation and then use these drugs that are so effective? And the answer to that is absolutely yes. And those are the kinds of clinical trials that we're the most excited about moving into the future.
Absolutely, and just a small plug for the work that we're doing now. The TIL, much like Jamie got, we're studying that in combination with pembrolizumab to see if that can improve the efficacy of how we treat our patients. Like I said, the patient comes first, but of course it also helps us answer questions about how the immune system's working.
Yeah, it's all very exciting. And thank you for all the work that you're doing, both of you and researchers everywhere on behalf of patients. So at this time, we're going to start answering some questions that we've been receiving on the Facebook comments. The first one, if not diagnosed initially, can melanoma be widespread systemically, or is local invasion the main complication?
So I think what that gets to is that every melanoma has its own biology. So unfortunately, of the 90,000 or so cases of melanoma that are diagnosed every year, about 5% are actually already diagnosed at the distant stage, meaning that there was never a mole that turned into a lesion, and that primary melanoma has never been found. Very frequently is the case that local recurrence may be the only problem that a patient develops. But we can find in our patients with metastatic melanoma cells in the blood. And so it's likely that that was destined to become metastatic disease. It's just a matter of trying to determine, it's more research to learn how we can predict when and how that's going to happen. Again, only approximately 5% of people are diagnosed with metastatic disease. It is usually patients that have developed metastatic disease that unfortunately contribute to the death rates for melanoma. And there are about 10,000 deaths from melanoma each year. And so what we're working on is how can we, in the very early stages, many dermatologists are actually working on this, how can we learn from that very first melanoma how to predict which ones may become metastatic and which ones will never be a problem again? It's sort of outside the realm of this conversation about advanced melanoma, but the more that we can learn how to predict, the better we can get patients prepared for what may come in the future.
Thank you. Next question is, are there any effective treatments for metastatic melanoma that has spread to the spine and brain? Dr. Luke, do you want to take this one?
Sure, absolutely. So I think it's important to point out that the therapies that we're talking about with immunotherapy really have the potential to be effective anywhere in the body that the immune cells will go. So just like you can get an infection that gets healed anywhere in your body, your immune cells can go anywhere in your body. So everything we talked about would be relevant to someone who had a cancer spot that was in the bone or even in the brain. I think one thing that this does raise, however, that's important to think about is that we're talking specifically about drug therapy here in the form of immunotherapy, but really the care of a patient with melanoma, or more broadly cancer in general, needs to be in the context of a multidisciplinary approach. So again, Dr. Goff and I have been working together for quite a while, but it really is the case that the medical oncologist should be talking with the surgeon and the radiation oncologist about what the optimal combination of all of those modalities might be to generate the best outcome possible for a patient. So in that sort of case, it's possible that a surgery could be useful. It's possible that radiation could be useful. But certainly I would say that immunotherapy in a case like that also could be a very helpful addition.
Great, thank you. The next is a two-part question. Can I join a clinical trial after starting treatment? And what kinds of questions should I ask my doctor about immunotherapy?
Do you want to handle that one, Jason?
Sure. The answer to that is, as with most things in life, it kind of depends. But generally speaking, we really think about cancer treatment sort of at landmarks. And so it's usually best to think about considering a clinical trial at a point where you're making a decision about your treatment. Because it really doesn't make sense to have people sort of just jumping around treatment to treatment because we want to make sure we know whether or not the treatment's helping. So usually what we suggest to people is that at the time when you need to make a big decision, like if it turns out the treatment you're taking is not working as well as we had hoped, that's probably a good time to collect all your information, maybe take a second opinion or talk to your doctor about a clinical trial. To really think about moving into the next phase from that point onto a study, onto a clinical trial. And that's not a hard and fast rule, but that's generally speaking how we like to think about it. What we really want to avoid is the idea that we would actually take away a treatment that could be benefiting a patient, because obviously that would sort of shortchange them the opportunity to get whatever benefit they were going to have from the treatment they're on. So I really usually suggest to people as they're coming up upon like a CT scan that they would have, if they're concerned that things might not be going the right way, that would probably be the best time to sort of think about a clinical trial or talk to their provider about their options.
Okay, the next one is about checkpoint inhibitors. What are the side effects of checkpoint inhibitors? Are there some that occur more often than others? Are they easily treated? And can they require me to stop taking the drugs?
So I think Dr. Luke,
Sure.
you want to handle that one, Jason?
Well, maybe
Okay.
I'll take the first crack at that. So the answer is yes, there are side effects, and they're generally speaking, as I mentioned, overactivation of the immune system. So, and they often come in the form of what we refer to as autoimmune problems. So if someone's heard of lupus or rheumatoid arthritis or inflammatory bowel disease, those are really sort of the most common types of things that can happen. Now, that being said, these side effects are now well understood with these drugs, and a doctor who has experience giving these drugs will be on the lookout and should be able to manage them relatively easily. Usually, if we catch them early, all we need to do is give some people some medicines, we refer to them as steroids, at home. They can take them at home. Usually makes this go away. And if it isn't too bad, sometimes we can restart the treatment. If it is severe, however, sometimes patients do need to be admitted to the hospital to get steroids through the intravenous route to really block down the immune system to try to get these things to go away. And in that context, really the decision to restart the treatment is a discussion about the pros and cons and the risks and benefits. I think it's really important in this space to point out, however, that many patients who have severe side effects from immunotherapy actually end up being the people who get the most benefit. So it's very possibly the case that they don't need to restart the treatment, because for any individual patient, we don't know how long they need to be on the immunotherapy treatment. And if it's working, I say, you know, if it ain't broke, don't fix it kind of thing. So in my patients who get really severe side effects, I usually take a pretty measured approach about restarting it. Often I'll get another CT scan after a certain number of weeks and say, well, if the CT scan looks okay, let's just wait and see what happens. But I'd also be interested in Dr. Goff's perspective.
Oh, no, absolutely. So one of the more interesting parts of my training was being here when we were doing some of the early phase 1 work with ipilimumab. And it was before we really understood what the side effects could be. And we started seeing patients with a lot of diarrhea, to be blunt. And we had to try to figure out where that was coming from. And it took a coordinated effort by a very specialized phase 1 team to determine that it was in fact the patient's own T cells that had learned how to attack the colon. And we were able to treat that with steroids. And what we found was that even when you give steroids, which is a general way of shutting down an immune response like that, it did not affect the patients whose tumors were responding. And so that's, you know, Jason touched on that point, but it's very key. Because of the way these drugs work, if they are able to unleash the cells that can attack the cancer, they may also unleash something else. Now, sometimes that's just against the skin. You'll get a rash, or you'll get itchy. But sometimes it can be against the liver, and some of the blood tests that we look at can go up. Sometimes it can be against the thyroid. You may need a little thyroid medication to get through that. But again, you have to weigh the risk benefits, just like Jason was talking about, because those side effects may be a harbinger of having a good outcome to the medication.
I can attest to that. So maybe our last question here, does melanoma run in families, and do people of color get melanoma?
So the short answer on does melanoma run in families is sometimes. So there are a few genetic profiles that will predispose. I think by far the more reasonable answer to that question is that light-skinned, fair-haired people tend to run in families, and those people are at higher risk for melanoma. If you have developed a melanoma at some point in your life, you are at a higher risk for having melanoma later. But the numbers that are a true familial, genetic, inherited problem are relatively low. As to the second question, yes, people of color can develop melanoma. There's a particular kind of melanoma that sometimes forms on the soles of the feet and the palms of the hands, under the fingernails, and those can develop in people of color.
And I just, from a patient advocacy perspective, important to note that it's often people of color who feel more protected and are less likely to take precautions in the sun, and can't stress enough that everyone needs to practice sun safety.
The best way to beat melanoma, as Jamie said in one of our practices, is not to get it in the first place. So prevention is key.
Yes. We have one more. Are there any predictive biomarker for metastasis in melanoma?
I could maybe speak to that. So that's an open question. There's a lot of research ongoing around now. There is actually an FDA, well, not an FDA approved, there is a test that is available on the market, which has not been evaluated by the FDA, that pretends to be able to test for this question, but it's still very nuanced. It's not a binary yes-no. It's still a risk calculation. And this is really something that people need to talk about with their surgeon as well as their medical oncologist after they have completion of removal of their melanoma to decide what the risk is that it's going to come back based on everything we know, and how are we going to monitor for it. I will just point out again that this is also a space where a lot of research is going on, and there are clinical trials of drugs trying to evaluate their impact after surgery, as well as just observational studies where we're just following people to see what the likelihood is. And then beyond that, we are working on blood tests and tumor tests and so on and so forth to try to figure out who is it that's going to have the melanoma come back. But it's still an open question. It's still something to talk about with your individual physician about what the best plan is for you.
Thank you, Dr. Luke. And unfortunately, that's all the time we have for today. Thank you so much, Dr. Luke and Dr. Goff, for spending time with us today. Is there anything you'd like to add before we?
I'd just like to, if you're looking for information about your cancer or your family's cancer or your friend's cancer, the internet is full of things that are scary. Always look for a reputable source. Cancer.gov is a great first place to start.
Dr. Luke?
And I would second that. I would second that to say that make sure that you look for information from reputable sources, and in fact maybe even ask your healthcare team for references that they would suggest would be good to go to look at.
Yes, thank you. So just want to remind all of our viewers that the video will appear both on the National Cancer Institute Facebook page and will shortly be on the YouTube page as well. If you would like more information, visit cancer.gov. Also, please be proactive. Look up clinical trials. Understand your options. Trials.cancer.gov will lead you to NCI's clinical trials. It's a fantastic resource. And seek out the experts, ask your questions, and be an active participant in your own care. Any questions that we were not able to answer today, we will be answered in the comments section later. Thank you all for tuning in to the latest media event hosted by the National Cancer Institute.
Nice job.